Hi, good afternoon there. My name's Andrew. I'm an academic clinician in Oxford, doing both full-time clinical for cardiology and machine learning research. And the work I'd like to talk about today is how, when faced with the challenge of COVID in Oxford, we brought the innovations of machine learning to clinical practice. And we'll talk you through how we came from an idea to try and speed up diagnosis for COVID and help streaming in an emergency department all the way through into seeing that into clinical use. And we're very excited about future direction of the work, looking at pushing down diagnosis from 1 hour into 10 minutes. So at the start of the pandemic, come last March, we found ourselves faced with problems with testing. And the majority of testing was based on the PCR nose and throat swab, which we've all become quite accustomed to. And last March, they were typically taking 72 hours to process, with the swabs needing to be sent to a specialist facility run by Public Health England. Now, that has come down, but it's still typically taking 24 hours to get a COVID PCR test back in a major tertiary centre in Oxford. And the impact of that is delaying the care of patients. We've seen that often there is a desire to try and control infection in hospitals. That means patients are having to be isolated for longer until we get those negative swabs back within 24 hours. The test is also imperfectly sensitive. It's thought the PCR misses 3 out of 10 positive cases, which has caused understandably concern in hospitals. And it's also an expensive test, around £50 a test. And that's had impact on how we've used PPE. And also the reagents for the PCR test have been in short supply. And so last March, faced with these challenges in our clinical practice in the emergency department in Oxford, we wondered whether we were able to help make a diagnosis sooner using artificial intelligence techniques. Now, more recently, the lateral flow assays have become part of household conversation, and there are concerns about these. Recently, there was a letter from the BMJ about concerns with sensitivity. We've seen varying reports from different groups, and so we're hoping that CURIAL would be able to provide a high confidence rule out for COVID, but much sooner than we can already with the PCR test. Our hypothesis was that if we were to look at all of that data collected in the first hour of a patient coming to hospital, now typically that would include a set of blood tests, a blood gas, which is a point of care test, and vital signs, we wondered whether we could use machine learning to use that data and pick out who would test positive for COVID and who was likely to test negative within the first hour. Now, specifically, we gave this up as a screening test. We wanted it to be a test of exclusion so that clinicians could have a lot of confidence in a negative result. And a negative result could mean you can safely triage patients into a COVID-free zone with a high confidence that that really is a negative result, which you don't quite get from the PCR with the limited sensitivity. And we're hoping also to deliver that rule out within the first hour of a patient coming to hospital, sooner than the 24 hours taken for the PCR test. And I'm delighted to say that when we developed our model and when we went on to test it, we achieved exceptional results with an AUROC of 0.94 on a test set with 50% prevalence. Now, of course, a test set with 50% prevalence is only as good as the test set. And actually, our experience in Oxford has been that we've seen a bimodal distribution with prevalence of COVID in the hospital varying from as little as 1% at times in the pandemic to as much as 40% of acute admissions. And so clearly, whatever model we developed, if we were serious about rolling it out into clinical practice, had to be something that was robust across a range of prevalences. And so we went on to see how our screening test would perform across a range of prevalences. Now, the key metric to look out for here is negative predictive value. That means if the AI test says that the patient doesn't have COVID, it means they really do not have COVID and they go on to test negative by PCR. And what we showed in our early analysis is that we were able to optimize our model to have a high negative predictive value, i.e. that clinicians could confidently be sure that this patient doesn't have COVID within 1 hour of them coming to hospital. And comparing the negative predictive value to the PCR test, which is the nose and throat swab, we were able to achieve similar, if not higher, negative predictive values, providing that high confidence rule out, but much sooner than the PCR test in hospital and using routine data. Looking at the features that were important in the model, we found that features like eosinophils, basophils, and vital signs were the most important. And that has relevance, as we'll go on to talk later, in terms of the feature selection. So we are now looking at slimming this down into a 10-minute model, but I will save that surprise for later. We went on to validate our model prospectively, which is extremely important for you to understand how your test works and its characteristics. And we did so for a 2-week test period across our hospital trust, covering 2 emergency departments in Oxford and Banbury. And we're delighted that we found that the test was highly accurate at 92%, but it also had a high negative predictive value of pushing 98%. And that meant that a negative result really could be trusted to be truly negative. And that would help the logistical aspect of streaming patients in hospital care while safeguarding infection control. Now, also forefront in our mind is the ethics and equality, as Indra was just touching in her introductory session. And so we had a look at our model and rates of misclassification in, first of all, over 60s and under 60s. Now, we know that COVID is a disease that discriminates by age, and so it's important there's no bias there. And indeed, our model shows there is no bias for elderly populations. Similarly, we looked at rates of misclassification between white British populations and Black and minority ethnic groups, finding no significant difference in misclassification, and also between men and women. And so taken together, the screening test that we had developed was able to give a confident rule out for COVID within the first hour of a patient coming to hospital. And that would really help with flow decisions within the emergency department. It would also cost a negligible amount running on cloud infrastructure using data that would be collected anyway. And looking forwards, we wonder, or we hope, and we're now gearing up our screening test to see if it can be used as a pre-screening test and help rationalize who should be receiving rapid PCR testing with limited capacity, and also perhaps helping with the challenges of the costs of significant amounts of testing for every admission. Now, we're delighted to say that we've been able to take something which started off as an idea in clinical practice into clinical practice. And we've been able to translate CURIAL into the emergency department with the support of an £82,000 award from the Wellcome Trust. We've been able to bring it to OUH. The clinical pathway we propose is that patients would continue presenting to hospital as they do and would be assessed through the existing pathways, and a prediction would be generated as soon as possible, i.e. as soon as the blood test results were back. The clinician caring for the patient would then look at the test result, and if CURIAL said that the patient was likely to be negative, that is a high confidence negative result, and therefore the patient can be safely triaged to a green zone or a COVID-free area. However, if the CURIAL result was positive, or if the clinician had an alternative concern over and above the model, they would be able to override the model and ask for the patient to be managed in an amber pathway, which is a potential COVID zone, while confirmatory PCR testing is awaited. Now, we hope that this model would allow 90% of patients to be rapidly triaged to green zones in the post-COVID era. Now, going forward from that, we mentioned that 8 out of our 10 top features were actually in only part of the blood tests and the vital signs, the so-called full blood count and the vital signs. And so we wondered if we could do clinically selective feature selection, i.e. use clinical direction to select which features are included. And we've done precisely that. Now, we've been able to install devices in the emergency department in Oxford that can give a full blood count within 10 minutes or a complete blood count within 10 minutes. And that means that all of the data needed to make a CURIAL prediction can now be collected in 10 minutes. And I'm delighted to say that we're prospectively validating this lightweight model that can be a 10-minute rule-out test of COVID in A&E or the emergency department at the John Radcliffe Hospital. And we started on the 18th of February, and we've enrolled over 300 patients to date. We've also made the CURIAL model accessible to all clinicians via haveigotcovid.com. This allows clinicians to enter in a range of blood test parameters and receive a high negative predictive value rule out for COVID, although we ask for the time being that this remains only in a research setting and not used to guide clinical care. We're also collaborating with University Hospitals Birmingham to externally validate our model. The initial results of that are available, and they show the model externally validates with similar performance to how it has in Oxford, and similarly also with Portsmouth University Hospitals Trust. We're also comparing CURIAL performance against lateral flows, and early data suggests a very encouraging picture on sensitivity, that CURIAL is able to achieve a higher sensitivity. We've published our research up until December in The Lancet Digital Health, And it was also featured in an editorial by the journal senior editor on AI milestones in COVID. We've also received positive media coverage, including from the UK government, but also from the University of Oxford and the BRC more locally. Now, in summary, CURIAL is a high confidence rule out for COVID-19 that can exclude the virus at high confidence in 1 hour. Better triage for COVID will reduce delays to patient care and help us focus limited rapid testing capacity. Importantly, it also has a role in the post-COVID era in helping reduce the number of patients who are needing to be tested and to speed up streaming within the cohort of patients coming to hospital. And point-of-care testing, such as our project CURIAL Repeat, may allow for CURIAL to make reliable predictions within only 10 minutes instead of 1 hour, both of which represent a significant improvement on the 24-hour turnaround time for a PCR test. I'd like to say thank you to the very many people across the University of Oxford and Oxford University Hospitals for their help, particularly Professor David Clifton and the Computational Health Informatics Lab. Also our collaborators in infectious diseases and microbiology at OUH, Professors Tim Pito, David Eyre and Dr. Brent, and the supporting team in the emergency department at the John Radcliffe, Drs. Ravi Patanchetti and Alex Novak. Together, we've been able to develop a project, take it from an idea rapidly into clinical practice in a pandemic. Thank you.